Good evening and welcome to the program. We are coming to you from San Francisco, California, and we look forward to discussing a new evolution in total knee robotics with you. I am John Gibson, Vice President of Marketing at Think Surgical. I'm very pleased to be here with Dr. Yair Kissin from Hackensack, New Jersey, and Dr. Alexander Saw from Fremont, California. Dr. Kissin, how are you this evening?
Good to see you guys. Thanks for having me.
Yeah, thanks for joining us from New Jersey. And Dr. Saw, how are you this evening?
I'm great. Thank you, John.
Great. Well, thanks so much for being here with us. Our faculty are going to walk us through their experience with the TMINI Miniature Robotic System and their perspectives on handheld wireless robotics for total knee replacement. In addition, Dr. Saw will be showcasing our first public demonstration of the TMINI 1.1 software, which features the addition of the TMINI Pro workflow. This workflow is focused on the positional refinement and optimization of the implant intraoperatively. Both of you have experience with a multitude of total knee technologies, and more specifically, robotics over the years. Robotics continues to be a heavy focus and is highlighted as an area of rapid growth in the orthopedic industry. Why do you think there is such a focus on robotics for total knee? And what is driving interest for surgeons and hospitals? Dr. Kissin, what are your thoughts on that?
I think I've been thinking about this for a long time. I think a lot of our colleagues think about this too. I think there are two main driving forces. Patients are asking for it more and more, so there is that. But aside from sometimes hyped up new technologies that haven't been proven yet, I think we're actually at the point where we are proving that these new technologies may actually hone in on that bullseye that we're trying to reach with those 15 to 20% of unhappy knees. Maybe we're missing something here, and maybe there's something still to be achieved, even though knee replacement is such a successful operation. Maybe we could do better.
Great. Dr. Saw?
I think Yair sums it up very well. I think as orthopedic surgeons, we're always trying to strive to provide the best outcome, the best surgery we can for our patients, John. But really, robotics and knee replacement specifically answers the question, can we do it even better? Our traditional techniques work. It's been around for decades. People do very well. But as Yair mentioned, maybe 15, 20% are not as happy as they could be. If these technologies help address those patients to give them quicker recoveries and better outcomes, it's definitely worth exploring. And as we've seen in the recent years, as you mentioned, robotic technology continues to increase in terms of patient demand and surgeon demand.
Thank you both for your perspectives. And it's interesting because despite all the noise and the interest in robotics, in the recent reports, we still see adoption at about 15 to 20% in the United States. These systems have been on the market for a while now, some of them to the late 2000s. In your opinion, why is adoption still low? What are some of the reasons maybe surgeons or health systems haven't fully adopted robotics? And I'll start with you, Dr. Saw.
I think even though it's been 15, 20%, that is a large volume, given it's a brand new technology or relatively newer technology. I think high volume surgeons, academic institutions, high volume private practice surgeons are using these robotic technologies. But you're right, why isn't it going to the masses? Why isn't it crossing 50% or even 30% yet? And I think some of the big hurdles, at least with traditional robotic systems, are their large size, how much footprint they use in the operating room. They're bulky and they're difficult to use and manage, both for the surgeon but the supporting staff in the operating room. They can be cumbersome. They change traditional workflows. So when you're using traditional robotic systems, you're typically changing the order and the way you're doing surgery with tools that you didn't train with. So while we're hopefully achieving the results we want to with the benefits of robotic technology, with our traditional systems and platforms that are currently available, it's led to a hurdle for hospitals, surgeons, ORs to adopt because of its limitations.
And Dr. Kissin, your perspectives?
I think that I agree with everything that Alex said, and that it creates the robots that I'm familiar with that are out there. They make the surgery a little bit different, or sometimes a lot different from what we're used to doing. And orthopedic surgeons don't traditionally like changing what they're used to doing, if for the most part what they're doing is more or less working. And so I think the adoption of a new technology like this, like what's out there right now in many forms, is such a leap that a lot of surgeons are just not ready to take that leap. And unless the surgery and the technology can meet somewhere where the surgery is still a familiar surgery, the way that they're used to doing it, with maybe some adjuncts to it and some enhancements. And then at the end, we get to the end of the case and we say, oh, I think that might be better than how I've been doing it before, but it didn't take such a big leap of faith to go into that technology. I think that's where the big hill to climb over is still. And I think that part of it is that I think a lot of surgeons, we're just used to not really recognizing that our patients are not doing as well as we'd like them to do. When a patient reaches 120 degrees at a year, we say that's a success, and they're telling you that they're not able to do stairs or ski or whatever it is that they cannot do. And we say, well, but this is still a successful surgery you had because you're at these milestones and landmarks that you've achieved. But that may not be good enough for our patients. And so I think there's a little bit of a sort of lack of responsibility on our part that maybe we need to make the robotic technology accessible, and not just in the operating room, but even just emotionally for the surgeon to actually adopt.
Got it. No, thank you both for that. And you guys kind of both discussed a couple different barriers to adopting robotics, whether it's ease of adoption, form factor, or different things from that perspective. You guys have both looked at the other systems on the market, tried different ones. So knowing those barriers, I guess what led you to adopt TMINI into your clinical practice? And maybe Dr. Kissin, I'll start with you on this question.
I'm pretty blessed where I am. The medical center where I work has been very supportive of new technology. We have a few robotic systems in our operating room, and I was part of the FDA trial for the original T-Solution 1, the bigger robot, the active robot. So I got started with this company and their technology early on. But at the same time, all the things we talked about, there have been some barriers. So when TMINI was coming to fruition, it was really looking like this may be the holy grail that we're looking for, that we're going to make things, take it from that technology that's been founded and been validated and been written about and has some really good qualities, but still some challenges and some missing pieces. So when the TMINI project started, it looked like this was what we were looking for. And I'm happy to say that as we've been doing cases, after doing some in the lab, translating that to the operating room, it's been a really easy, very smooth transition.
No, thank you. And Dr. Sawes, we've talked a few times about your story of adoption, and you had shared you didn't jump into the anterior hip, wave right away. You kind of waited. Similar on robotics. So I guess you kind of looked at what was out there. What now made you decide to adopt something like TMINI?
You're absolutely right. I like always being at the forefront of technology and advances, but I always have a little bit of caution. Want to make sure that the bugs and kinks are worked out with the initial rollout and see what sticks and what works. And while we all would agree that we like to see the benefits that current robotic technologies can bring us, it's executing it in the operating room. And so if it takes us twice as long to do that surgery, if it's not efficient, if it's cumbersome for the surgeon and for the staff, it's just not going to work in a day in, day out practice. We're high volume private practice, so if we're doing a number of cases, it has to be an efficient workflow. I think Yair mentioned something earlier that I'd like to highlight, that I almost wish that this technology came out first. I think that the traditional platforms that came out, it's almost a disservice that it jumped to that, because again, it changed workflows that traditional surgeons are not trained in. We have to learn different ways to do things. We have to trust the system more so than anything else that we're used to using our typical tools here. These are all tools with TMINI that we're familiar with, and it's a workflow that we're familiar with. So we know how the surgery should go. We get the benefits of the robotic technology, but it's much more efficient. It's much easier, as we'll see in the lab. Right, the sterility issues, having to sterilize other traditional robotic arms, have two bays and two systems. It's just a lot in the OR. It's the efficiency and the ease of use of this which made it so easy to adopt clinically.
Got it. No, and I appreciate that. I think, one of the surgeons in our early user group said it's the benefit of robotic precision, but it's keeping you familiar with the instruments that you're trained on, 4-in-1 block, distal cutting jigs, and putting the saw in your hand.
That's right.
No, and I appreciate you guys talking about the different barriers. One other topic I'd want to, talk about this evening is obviously the different business models that these robotic systems operate on. And at Think Surgical, we do have a passion for developing products that are easy to use, which you guys talked about the efficiency. But one of our core foundations is of empowering surgeon implant choice. Through our growing list of implant company partnerships, Think Surgical enables the most implant company, systems, and design philosophies of any orthopedic robotic system on the market today. Currently, we have 4 FDA-cleared implant systems with our partners Innovis, Total Joint Orthopedics, TJO, Ortho Development, and United Orthopedics. And we have publicly announced partnerships with Link, B1, and Max Orthopedic. And we also have an additional handful of signed collaboration agreements with future partners that we'll announce in the future. I'm curious from the surgeon perspective, and maybe even the hospital, or if you operate an ASC, what is the value of open platform compared to these other closed systems where you have to use their implants? And I'll start with Dr. Kissin.
I think you already said it, John. You know, there are a lot of different ways of doing this operation well with a lot of different implants, and these days we have to also keep our eye on the bottom line. And as I've gotten into a little bit of ASC in our neighborhood, you really start to look at bottom lines a lot differently. And robotics is maybe a little bit more expensive. Maybe each case costs a little more. But if you can make the implant cost a lot less, then you're really enhancing the surgery potential for that patient. So surgeons who are very happy with what they use say, I don't want to give up my implant so that I can use that proprietary robot. And on the other hand, surgeons will probably at some point say, well, I want to use that robot. I might have to use a new implant. Are there good ones, you know, quote unquote, right? Are there good ones on that platform? This implant agnostic is a really interesting model because nobody else has it. It's like having your GPS in the car, pay a lot extra for it, or just have it on your phone, on your dashboard, and you can use it in any car you want. So that's how I look at this. And it's not just implant agnostic, it's technique agnostic. We have successes. We can't agree on how to do knee replacement today after 40 years of knee replacement, but we can do this operation with this tool with essentially, in theory, whatever kind of implant can come to this platform potentially in any philosophy that you want to do your knee replacements that you believe in. So, and we've shown it. So it's really interesting to see that there's real freedom here, that you're not locked in.
No, I appreciate that. And Dr. Saul, I'll get your perspective. I was curious, I was talking with a surgeon a few weeks ago, and he made the comment of a surgeon can't use the same implant for every single patient in case. So I'm curious, in your perspectives, do you use different implants for different cases? I don't know, nickel allergy or things like that. But is it feasible to use the same implant on every single patient if you were closed down to that?
Great question. There definitely are surgeon preferences. Some surgeons like to use the same implant system or same brand in all of their patients. Obviously, with the traditional robotic platforms, they are dedicated to do that using one implant design or partner. But I do currently use different vendors. I do agree that there are certain nuances of different vendors that you'd want to choose for different types of knees. And so I think having flexibility there is beneficial. Like Yair is saying, the benefit of having an open platform system certainly is financial for the ASC. As the ASC momentum continues to grow, more and more procedures are moved to the ambulatory center. Having the ability to manage cost is a major factor, and implementing robotics and having freedom to do that is certainly helpful. The other benefit of an open platform is when you go to large groups, so large groups of surgeons, maybe they want a robot and to have a technology for their community, but if they have a robot, the only people who can use that are those surgeons who are willing to use that single implant company. If you have a large orthopedic group and you have an open platform like this, they could potentially use 3, 4 different implant designs of their preference all on one robotic platform, so not as limiting. And that's what brings up something that I've been thinking about, and it's an interesting thought, and I'd be interested to hear what Yair has to say. That for decades, we've been focused on the subtleties of the implant design, right? When you were in training, when I was in training, that's how we picked and chose what implant we use, because this one had a little change here, a little modification here. All the emphasis was on that implant design. Then robotics came. All of a sudden, we're not talking about that at all. Really, what trumps everything is which robot I'm going to use, and suddenly I'm going to use that implant regardless of that implant design, even though I might have never used it before, strictly because of the robot. But now, when TMINI comes onto the scene, I think the conversation is going to change, because now the emphasis can go back to what implant features and designs appeal to the surgeon the most. Because with TMINI, you can use obviously many different implants. So I'll be interested to see if the focus now goes back to surgeons picking truly the implant designs and features that appeal to them.
Great. Thank you both for those perspectives. Dr. Saw, it looks like they're ready for you in the lab. So we'll have you head on in and Dr. Kissin and I will continue on the conversation while you're getting ready. So Dr. Kissin, why Dr. Saw is getting ready in the lab, can you just talk the audience through what's been your early clinical experience? How has it been from a learning curve? Just kind of talk through people what that transition's been and how it's been going so far.
Yeah, no, I've been very lucky about how things went. First of all, not just is my hospital friendly to opening their ORs to different robotic systems. So I've had a touch with a few different systems, but also I'm very blessed with some very talented staff. So it didn't take very long. However, I will say that I try to be one of those surgeons who is kind of sensitive to the staff and their time, because I do know that with some of the robotic systems, the bigger robots, it did take a lot of time for them to set up the cases. And I believe if any surgeon really asks their staff if they truly like to do robotic cases, I think we all know what that answer might be across the board in most institutions. It doesn't seem to be the case with my experience here. So you can't do this case without the setup. And the setup is extremely easy, extremely efficient and fast. You don't even notice it. We did a flip room. It wasn't a problem. When the robot part of the case was done in the one room, moved it over to the next room, and in minutes it was ready to go, and there was no blip as far as any kind of time lost. So that's, I think, where we kind of tend to forget a part that this system really sets itself apart from, as well as, and we only touched upon it, and you're probably going to see it in the lab, the choreography of the big robots where you're doing your approach, everybody's in their regular spots around the OR table. And then, I call out, places, everyone, places. And now everybody has to move around, move away from one side of the room, line of sight. Then we're half cutting and moving, and we're, so there's really none of that here. Everyone stands in their regular places where they normally would. I'm at an academic institution. I've done total knee replacement with one assistant. I've done knee replacement with 3 assistants. So now we have medical students, we have residents. There's room for all, and I think that's something that we tend to forget. And to me, that's very important. Having said all that, we still did the cases efficiently. And yes, I was at an advantage because I had done the cases in the lab, so I certainly had some practice. But I do think that part of the adoption of robotics, no matter what, everybody has to learn how to register and put in arrays. That's pretty much every robotic system. Once you've figured that out, then it's about the robot. And the cases, once that became familiar to the staff, to me, then it's almost like, well, which robot are we now using, right? Now bring in the robot, right? With this one, it just seemed like it just continued to flow, and our times were very acceptable. I was really pleased. It was the kind of thing where people were coming in from the other room to take a look, other techs who I'd worked with on the big robots. Oh, we wanted to see the case. They came in, we said, sorry, it's over. And that's what we kept experiencing. So to me, I really think that part of the ease of use, you're going to keep hearing probably tonight, and you're going to see it as Alex does the case. But I think it's that ease of use ultimately. Yes, we want to get the result we want. That's all robotics. I think we can all agree. We have the accuracy, we have the precision, but how do we get there? Getting there is really important. And adding 20 minutes to a case, adding 30 minutes to a case, the first time a surgeon looks up and that's what their cases are looking like, they're going to stop doing this. But if their cases are within a time range that is very acceptable and they're getting the result they want, that's a win.
Dr. Kissin, I think you bring up a unique perspective. Every time we talk about robotics adoption, it's about the surgeon's learning curve. And I think as an industry, we've overlooked the efficiency curve or learning curve for the staff, right? Because if the surgeon wants to adopt a technology, the staff will kind of learn that and adopt it and so forth. So you're bringing up a unique perspective that this could potentially also provide some efficiencies and maybe less stress for the staff to adopt a robotic system as well, which hopefully, if it's less stressful, easier to adopt, they're happier in your room, more supportive of the technology they are adopting as well. So that's an interesting perspective. The other topic, while we're waiting for Dr. Saw, that I want to talk to you about is there seems to be a dichotomy in orthopedic robotics of image-less versus image-based system. Obviously, the TMINI Miniature Robotic System is a CT-based system. I know you have experience with that type of technology in the past and now with TMINI, so I'm just curious, from your perspective as a surgeon, what does the CT-based planning deliver for you in terms of value? And then maybe talk to me about, is there value of it from an intraoperative execution perspective?
Yeah, that's really a great debate. I'm still on Team CT scan. It is an extra step. I'm very sensitive to explain everything to the patient. I do explain to them that is an extra step. I explain to them why I think it's a good idea. Getting a pre-op plan and corroborating it with intraoperative information on where the patient's anatomy is, I think is what has led to the accuracy of these robots. And without that preoperative plan, I'm not sure that we get the same accuracy. And I've had some experience with imageless. It's very nice to not have to have an extra step ahead of time or look at any more images ahead of time, do a little bit more work ahead of time. But if you do all that work on the back end, then it comes out the way I think you want it to come out at the end. And to me, that's the most important thing, is the result. I also think one of the biggest advantages, and this has been shown in multiple articles I've seen and in our own experience, size. So knowing what the patient's implant sizes are going to be ahead of time, especially I use two implants, one that femur tibia, you could put whatever femur and whatever tibia pretty much. And then the other system that I use that is on the TMINI system is a one up, one down system. To me, that's one of my biggest challenges in the operating room, is cutting that tibia, trying to figure out which size the patient is. Do I sometimes have to compromise? I hope I never have to compromise, cutting a smaller femur to fit a smaller tibia, or putting on a bigger, whatever it is. Knowing the sizes ahead of time, I think, is one of the biggest efficiency makers in this whole system with a CT-based robot. Because what happens is then, if we really look ahead and we're able to really make a good economic and efficient model, we don't have to open up a whole lot of stuff then for this case. We don't have cutting jigs. The cutting jigs come with the robot. We don't have to open too many trials. We don't have to open 1 through 10. We can just open the trial that we think it's going to be and maybe have peel packs, one up, one down. And we probably won't even need it. So knowing that ahead of time, I think that's the biggest thing for me too. Those two things: corroborating pre-op and post-op, and getting a good pre-op and intra, and getting the sizes.
No, I appreciate that. And if I could sum up what you're saying, it sounds like predictability in the plan up front, potential efficiencies of instrumentation intraoperatively. And it sounds like Dr. Saw is getting antsy with a scalpel in the lab here. Dr. Saw, are you there? Are you ready?
We are here. We are ready, and enjoyed the conversation and discussion you guys had. You guys took so long. This is actually our second knee. We just finished the first one, but we'll do the second one with you guys now.
Great. Well, Dr. Saw, it's your show. We're handing it over to you, and we look forward to the demonstration.
Perfect. Well, thank you guys again for being here this evening. Look forward to showing you how this works in our lab, of course. And as you see on the camera here, we have our knee positioned and draped out. The team's already done that for us. We're going to go, the exposures occurred as well. We're going to go through putting in the tracker pins and doing registration and whatnot. But you can see the overall form factor of the tower that we use. So you can see it's just one pretty small and slender tower across the table. It has a sterile draped screen so that I can interact with if I want to, or our assistants in the OR can, whether it's your physician assistant or nurse or resident or fellow. And importantly, in this lab, we have the lights. We have a ton of cameras in here for this evening. But what you can see is that the tower has our overhead line of sight camera. So what's very different here is our assistants are on the opposite side of the table, probably the same way you would do your traditional surgery. They don't have to dodge and duck and move from a camera that's behind them and low. So what's nice about this overhead is it really fits well in the main hospital, in your ASC, doesn't get in the way of other lights or booms or other things. And as an example here, we have all kinds of lights and extra cameras here, and it's not a problem at all. But you're going to see the benefits of this overhead line of sight camera. Yair, you would agree with that in your experience?
Yeah, it's all normal, everybody, and I can even have an assistant to my left where you are a medical student in our case.
Which is great. You don't have to do the dancing and the other things of your assistants getting in the way of the traditional cameras. So on this screen, we've already done the pre-op planning based on CT. We've figured out the sizing, as Dr. Kissin mentioned before, and so we can just confirm everything on that screen. Then we can move forward. Once we've confirmed the patient and the case, then we can go ahead and put in our array. So again, typically here, you would do your exposure as you normally would. You can resurface the patella if you want to, but then we would go ahead and place our trackers. And this is very similar to how you would with any other. I usually start with the tibial side, and I'll go maybe 4 finger breadths below. They do provide this guide pin so that you can make marks, basically just leave little indentions, and I would make 2 small stab incisions there. And then by using these, we can place our pins. Thank you. This is pretty routine, similar to any other system. We have Larry and Rudy here helping us. We appreciate them being here. But this keeps them parallel, makes it very simple so we can put on our brackets very easily.
And Dr. Kissin, while Dr. Shaw is doing that, this is pretty standard for all robotic systems, array in the tibia, array in the femur. Any differences here that you've seen?
I think the main difference is as your team learns how to do this, what Alex just did, probably your assistant would be doing, and then you can move on to the next step. I think these are very routine points where any surgeon who is interested in adopting this kind of technology, you just have to learn how to do this. It's not that far, not that bad to learn.
And Dr. Kissin, the arrays here look a little bit different from my experience with other systems. Kind of have some batteries in there. Is there any difference from these in terms of active or passive tracking? Any value of that type of tracking over some of the other systems?
I think that as long as, the line of sight is right above you and you know where to put these things and nobody has to move out of the way, this is really not that bad to the workflow.
Yeah, I think one thing we've noticed with the user surgeons, right, is the active tracking is if you get any blood splatter or bone debris on some of the passive trackers that are on the market, right, you have to use that towel to clean it off, and the active tracking has the ability to kind of still communicate through that.
I just wanted to show how you can see through the camera, so you can see if you can see the trackers. Again, this is overhead, so you can see our assistants are across the table. I'm here, but there's nothing really in the way, or retractors or other things. So from coming overhead, up above, we can move this where we want to put this right in line, as you can see there. Is that coming across okay?
Yep, we can see it.
So once we have these in, once we install our tracking arrays, so when we pick the size of the implants, you can see it here on the side. You can make changes here if you would like to. You can also, for example, make changes to anything in terms of the implant placement if you wanted to. So you could do those things if you wanted. So you can see the various gaps and other things like that. But I just wanted to show, go back just to show, sorry, close that layer. Yeah. And hit next there. We'll go next. So you're used to, with other robotic technologies, doing various movements and rotations, but here, really it's a very quick and easy maneuver here, whereas you can see on the screen, you really just have to move the hip in one plane there quickly, and then it can very quickly obtain that information. So that was it. That was as quick as it was. You don't have to do the traditional rotation and other things in track time. It's really just that hip flexion. But now if you go back to that screen layer, if you go down, yeah.
And Dr. Shaw, while you're pulling up the planned implant screen, that's something you could do prior to the procedure. You're just showing it right now.
We're just showing it
after
now.
the arrays.
That's exactly right. And the only reason I bring that up is because let's say, you've made your plan and you did it on CT scan, but let's say when you get into the OR, you forgot that they had a 20-degree flexion correction contracture, or had something that you didn't remember on your pre-op plan, or maybe your note you didn't record as well, or someone in your office. If you can get into the OR at this point and you realize there's something you want to change, maybe you want to take more distal femur, for example, you can do that here. So the screen allows you to change it before you've done anything else. So you haven't assessed gaps, you haven't looked at range of motion, but you could change anything at this point also. So you can do it pre-op on the CT planning, and then you can do it on this screen as well, or of course, after we obtain soft tissue balance. We'll go over some of these modules, how you can change things in a moment.
Great.
And you can see, again, you can see how you can change it, whether it's in extension or flexion. You can see the different planes of being coronal, the coronal plane or the sagittal plane, and then the flexion as well. So you can see all those things. Perfect. Okay.
Got it. So it looks like you can change the sizing. You have all degrees of freedom, and basically as you click in each of the planes, those movement controls to optimize the implant come up.
That's exactly right. So multiple levels of, and you can choose to skip over if you want, if you just want to go to assessing soft tissues and soft tissue balance. But again, you have that option, John, if you wanted to change it at any point, because maybe when you first got in there, when they were prepped, you saw something that you didn't remember or see when you're doing the CT scan. So now we're going to move on to registration. And so you can see this is the digitizer here. And I think this is important to recognize. Some of the traditional ways of registering can be somewhat cumbersome, right? How you hold them, are they raised pointing in the right direction for the camera? You can see this is a very ergonomic type digitizer. You can see that the overhead camera is going to see these sensors very easily, but it's easy to fit in your hand with a trigger. So very easy to use. And so you simply move it into the line of sight, and then it recognizes the digitizer, and then you choose the femur, and then you can begin your registration process. Now, this is pretty similar to how you would do it with other systems, but it's a little bit easier, I think, in my opinion, just given how the form factor of this digitizer, how easy it is to hold it in your hand, and again, not to have line of sight issues with your camera. You do try to pierce through the cartilage, and you do try to make sure that you get down to bone, because obviously it's CT based. So that was just a rough registration, but then you can see here's our registrations of our distal femur. So what's nice about this is you see large areas that you can register, but you can also see that it's tracking where the tip of the digitizer is going. So again, piercing through cartilage, but once you get the flow, it can be a very quick and easy process going through the cartilage. But it registers quickly and it acquires points very quickly. Yair, do you have any comments about this registration process compared to some of the other robots that you've done?
Yeah, exactly what you said. And I think that one real important point that you mentioned is that pre-op plan that comes off of the CT scan. I can't stress enough how important it is. It's giving you numbers, not a 5-degree distal femoral valgus cut. It's not 5 degrees off of the cutter. It's a degree or a number off of that patient's personal anatomy, and that's where we start. And now what Alex is doing right now, what you're doing right now, is corroborating that pre-op plan with the patient's own anatomy, and piercing the cartilage down to the bone. Super important, because if it's not, then those two plans don't get corroborated and you'd fail registration. And you really would want it to fail registration, because it means you're not going to get an accurate result. So when you do pass registration, which how many minutes does it take? Most of us, I think, in the 3 to 4 minute range, as we get facile with it. It doesn't take long. And if you pass registration and you have the pre-op CT scan, to me, that means you're going to get a good result.
Yeah, I agree completely. And I was just trying to show you how quickly this can be done, but also how nice it is just to, again, have large areas that you can choose from, so that you're not trying to find one small spot. I think it just makes it faster. And I like being able to visualize the tip of the digitizer to know where I am, what I'm trying to register.
And Dr. Shaw, a couple of things you had mentioned, a couple of differences, right? It's kind of the pistol grip. It doesn't look like you're using a foot pedal. or anything like that. And it looks like you were able to advance the procedure by yourself, not having to have a rep click a button or anything like that. Is that what's kind of happening in the OR right now?
That is true. It's all in the handpiece, John. So it's all in this trigger, makes it very easy. There's also a back button. So if I didn't like one of these points for some reason, I could easily go back. So that's nice as well. And then again, the confirmation check. So you can make sure that you're where you think you're going to be. And this will confirm what you just registered. So I like that part as well. But you're right. You can either touch it yourself, have someone else touch for you, or just hold a button to move forward.
Yeah, I think it's a great demonstration of what Dr. Kissin was talking about, the robot choreography earlier, right? You got an assistant on the contralateral side with all the systems. You wouldn't be able to have that assistant there. And then to the choreography of the rep understanding where you want to go in the procedure and advancing the case. But here you kind of have full control and the staff can stand where they want.
That's exactly right. Now what you can see here is that when we move to the screen, we can assess the gap. Now that we've registered, now we can go to this and we can see exactly what the gaps are. We can see what our planned resections were, our planned HKA, our varus valgus flexion. So you can see all that now. So a lot of this information is things that we've entered pre-op, but now we have the ability to assess again what the range of motion will be and what the effect that will have on the soft tissue balance. So you can see here, we can look at flexion extension. So very similar to other systems out there. What's nice is you can see it moving live, right, in both the sagittal and coronal planes. You can see it move through a range of motion. So you can see the gaps as well. So you can look at the gaps. You can assess what they would be in flexion, extension, and maximal gaps. So it's capturing that for us. So it's telling us how much there is both in extension and then when I move here in the flexion. So you can see that here. So some people, depends on how you like to do it. Some people like to use something like an osteotome or something else to open that gap. And so you can certainly do that here. Hopefully this is showing you how the numbers can change on the medial side based on how much opening there is when we stress it.
And Dr. Saw, are you having to press a button to capture those gaps, or is the system capturing it for you? I guess how's that working?
Yeah, the system captures it for us, which is really nice. So it automatically captures those maximal numbers there. So as you can see here in flexion and extension, you can see the gaps here, and it changes based on where we are, but it's showing you really all the data points that we're used to right here on the screen. Yair, anything that you typically look at or your workflow here, really can center, your eye centers right here on the center of the screen so you can see what your gaps are.
That's exactly where I'm looking. And if I'm within, I mean, obviously you'd like to be real close to equal, but between 1, maybe 2 millimeters, but we don't even need to be 2. 2 is even too much sometimes. And we can really dial it down and really tailor it to what we want.
That's right. Now, once you get to the screen, you can make changes here. You can see how you can touch the screen and these options come up. You can also go to the planned implant screen. So the thing we looked at before, remember, John, we could change this before we did anything to the knee itself. If we saw something in the OR before we started that we wanted to change, or we can change it now that we have this information. So you can see, again, the same layout. But what's nice here is you can also see how the implants are planning to fit on the bone, whether you're going to notch, for example, or what the resections are, things like that. So resection depths, but the gaps are in the bigger numbers right down the middle, right? So that's coming across okay, hopefully on the video screen. These gaps, we want to make them a little bit smaller just for this particular system. So you can see you can tap what you want to change. So here, this will be changing things with the knee and extension. So you have the ability to move that component up or down, for example. So if I wanted to close these gaps, I would move this tibia up a little bit, and you can see how that will change these gaps down to, 21. You want to be around 20 or 21 just for this particular implant, but you can see up and down is very easy here. You could shift it right or left as well. And then for the tibia, you can change the varus and valgus, of course, as well. So if you wanted to make a change, you can change pivot points importantly. So this is if you wanted the pivot point to be on the medial or lateral side or in the center. It's a lot of that surgeon preference. I think a lot of systems now actually have different pivot points. So you want to know what your particular system currently is doing. But here you actually have a choice depending on your preference. And then you can see how you can certainly change some of that here. So you can change the varus valgus. You can see it changing here. And you can also simultaneously see the effects that it has on the gap there. And then same for femur. So if you wanted to distalize the femur, if they were hyperextending or other things, you can certainly move that down. You can see how that will change things. And you again can change varus valgus of the femur, and you can also change the pivot points here. So I think that's nice flexibility of this program to be able to have surgeon choice in where they make that pivot. I think a lot of surgeons don't actually know where their particular systems are moving the implants. Yair, do you agree with that?
Yeah, I could tell you because this part was new to me here and I didn't know. Absolutely. And I think the irony is that surgeons were screaming that they want to be able to move the implant and change the implant during the case. But I think for me, the ultimate goal is have my pre-op plan and change nothing. Because ultimately, if we can place that implant in the right place, just about, I mean, I play that game where, really do very minimal work in here. And it usually ends up being that way. We do make adjustments if we don't like the numbers, of course. But in general, yeah, these little tweaks are really little, usually.
Yeah, I would agree that the CT, we were talking about the importance of CT, Yair. I think CT-based technologies do get us very close. It does help us because a lot of it is a bone type surgery, but certainly for the gaps and soft tissues and the balancing, this gives us the ability to make those fine-tune adjustments, as you said. So it's nice to have that flexibility, but I do agree with what you said. And I do want to show you here as well. So let's say that you wanted to rotate this, change the flexion or extension in this femur. What's nice about this is that this will actually give you a notching warning. And I don't know if you could see over here at the same time, as you're changing that, the plane of where that cut will occur is changing as well. So I think that's a great feature to try to give some guidance to surgeons, whether the changes they're doing here, what impact that will have. Same with rotation and other things. You can change the internal external rotation of the femur on this screen. But what's nice is, again, if you're going to do notch or do anything that maybe you didn't intend to do, you will get a warning and you can see it here visually.
Thank you. Yeah, and Dr. Kissin, I think you had mentioned it earlier, right? We're implant agnostic, but technique or philosophy agnostic, right? And that's why, we're talking about positional refinement and optimization of the implant. A lot of systems have gone down a gap balancing technique, which can be somewhat bifurcating in the industry, right? That's not all of the surgeon's goals, right? To get equal gaps. Some prefer kinematic alignment or patient-specific alignment, all those things. And really what Dr. Saw is highlighting here, I think, is for you as the surgeon, after you choose the implant you want, there's a specific way you want to put it in, and the software allows you to place that within a 0.5 millimeter, 0.5 degree clicks of where you want to put it every time.
Any questions about that, Yair, before we move on? Show the...
No, those are my steps too.
Okay, perfect. So let's show you the handheld TMINI robots. This is really what you're here to see, and you can see it's familiar, right? It's like a drill, just a little bit smarter. But you can also see that it's sterile, right? There's no drape. So unlike traditional robotic systems, we have the draped module on one side and a draped arm of some type on the other, which I always worry about sterility, to be honest, because it's very hard to get these things sterile, bring them in and out to the table. Here, we kindly term this the naked robot in our OR because there's no drape on it. The whole thing is sterile, very, very easy to use, and also very familiar. So here, you can't see the sensors are on top again. That way it can go straight up to the overhead camera. And so here, you can see you have your pin, and on the screen, you can see that we're planning to do the distal femoral cut. As long as the camera can see everything, I'm holding the trigger here. And so I just wanted to show you that I'm holding it, but it only turns on when I'm in plane. So if I move up or down or out of it, it will not spin. So it's only going to spin, and I'll only be able to advance it if I am in this particular plane. So hopefully that's coming across on the video.
Yep, we can see it.
Perfect. And so once you're in plane, once you find the place where you want it to be, you can advance as so. So first pin goes in, second pin, again, it's going to find that same plane. So you can see here, I can move anywhere in that plane and I'll keep it spinning, but once I deviate out, it's going to turn off. So hopefully I'm showing that there. Obviously, I don't do it this way when I'm actually putting the pins. I just put 2 pins in. But then these 2 pins are in plane based on the robotic technology, and then we put on this cutting guide.
So it looks very similar to a traditional manual instrumentation, right? 2 pins, place your distal cutting jig, and then now you're going to execute it with your traditional saw.
That's exactly right. So these are all things that we're familiar with. I think all orthopedic surgeons would agree they know how to make a cut with a saw through a guide. And so now we can just do that how we would be used to it.
Great. And Dr. Kissin, while Dr. Saw is making that cut, we had a question from the audience, which was, Obviously, we're seeing the arrays placed here, extra incision on the tibia. The question was, can you place the tibia array within the incision?
Can you? Yes, I haven't yet. I'm not quite sure. I've been thinking about doing it, but we're trying to keep the incision small. So I would have to currently, I think I would have to extend my incision distally in order to do that. So I would rather make the two poke holes, which don't really cause much issue. I would urge that surgeons put in the those pins, especially in the tibia, so that you don't have pin issues. That is not something that you would want the least trained person or medium trained person, junior resident or anything putting those in. That's something that we should be responsible for, I think.
Got it. Thank you.
I just wanted to show at this point, you can confirm your distal cut, or any cut for that matter, with the digitizer, and it'll show you the depth. So you can see how it changed. When I brought this in, the condyles disappeared. So there they were. But once we do the resection, then we can look and see where our cuts are, and we can determine what the depths are as well. So you do have to be a little bit careful because obviously there's cancellous bone and you can drop in that. But what's nice is that you can, again, confirm your cuts and see where you are with your cut. So I like that. Being right on that without falling into the cancellous bone. But you can see here, it's 0 millimeters.
Got it. So you have an ability after you make the cut, verify the accuracy if you want.
Absolutely.
Something that's an option for the surgeon.
So then there's a button, a single button on the back here, and you simply advance to go to the next type of the procedure that you want to do. You can change your workflow. You can cut tibia first or go to femur second, whatever you want to do. Here we're just doing distal femur and then doing our 4-in-1. So you just hit this button to advance. And then the same concept, right? I'm holding the trigger and it will only spin when it's in plane. Then you can advance that pin.
So now, Dr. Saw, you're just pure execution. You're not, you've already dialed in your plan and you're just purely executing now, not really.
At this point, that's
Yeah.
true. You're exactly right. So we have it CT based, and now we're just executing what we want to see. And so this is a jig that will allow us to put in the 4-in-1 holes based on the implant that you're using.
Got it. So the distal femoral one's a universal cut jig for distal and proximal tibia. That plastic guide block you just put on is specific to the implant manufacturer you're using.
That's right. But this is already set in, right? All of our rotation, any of our changes that we had, it's all set.
Got it.
And we already know the size, so they've already pulled the block. And so now we get to go back to using our traditional saw and things that we're used to. Yeah. So I routinely like to hold these 4-in-1s down with pins on the side, just because of the quality of the bone. You never know. Yair, do you pin down your 4-in-1?
With screw pins every time. I'm
Yeah.
trying to do more and more uncemented and got to make perfect cuts.
Yeah, absolutely. You don't want something to move in between cuts or anything else. So I agree. It takes a touch longer, but definitely worthwhile. So you make your cuts as routine.
That's different, maybe why he's making the 4-in-1 cuts. You brought up a topic of cementless. You said you're trying to move that way. Has robotics played into the thought process of adopting more cementless, or has that just been a recent topic that you're interested in and implementing more?
No, not recent at all. It's definitely something that I've been trying to do more and more. It's always an intra-op decision. If that saw goes through the bone like a hot knife through butter, no matter what the age of the patient is. I had a 50-something-year-old who was like that, so she got cement, but we also get 75, 80-year-old patients sometimes with rock solid bone, and doing cement just feels wrong. So if you don't have good, accurate cuts, no matter what the quality of the bone is, then you absolutely cannot put a flat piece of metal on a not flat piece of bone. So you got to get this as close to flat as possible.
Got it. Great.
Anyone else here, Tom?
I'd also bring up, I'm a tibia first, and this allows you to do tibia first, doesn't matter. You want to check your extension gap after you did your tibia and distal femur, you can. Alex, I don't know if you ever do that, or me personally, I've been just trusting the plan and been happy with it. So I just keep going like you are.
Yeah, the plan is very reliable. I would agree. But what's nice is it's very flexible, this system, so that you can do whatever your typical workflow would be. A home in or something. So once our femur is done, again, we can bring our TMINI back in, and we can now move to the tibia. Do you have an Army Navy by chance? So again, pins are going in here based on what we set, the depth of resection we set on CT. We did move it up a little bit because we wanted to change some of the gaps. Thank you. And then we use that same block. So I will take this piece out. I'll take the saw back.
Yeah, I think that's something, Dr. Kissin, in my experience with robotics, we've seen, trusting the system at first, and sometimes with robotics, things look a little different than you've gotten used to your standard manual and how you put things in, and it looks differently. That's one of the things, and I'm curious, in your early experience with TMINI, have you gotten to the point where you trust the system and what it's telling you, or are you still a skeptic, I guess, with this system in your earlier experience?
Yeah, you try to be skeptical because that's just our nature, and you find out that you're wrong and it's right more often than you'd like to admit. So I'm a trusting in this technology at this point.
Great.
So here's through the slot. And John, to your point, sometimes it's really hard to trust the system because it does look like an unusual cut. But what you have to remember is this is based on CT. So sometimes it'll look like a large or deep cut from the front of the tibia, and then you make that cut, and it's, if you cheated yourself, it'll be shallower than you thought it would be, even because it looks so deep from the front. But the CT scan, to your point, it's been very trustworthy. I've been amazed, and usually when I thought it was too much, it ended up not being too much. It was just right. Yeah. Perfect. We can take these pins out. Yeah, go ahead. And then usually we would put in femur. With this particular system, you can put in tibia, put in femur. I usually put in femur at this stage. Perfect.
And while you're putting the trials in, Dr. Kissin, I was going to ask you a question. For the system we're using today on the broadcast, just for having to choose one is the Innova system. What are you planning on your distal femur? Are you planning the thickness of the component 9, or what are you generally planning with this system in your practice?
So this is the same system I use, and I adopted this system close to 5 years ago for two main reasons. I was really interested in that ultra congruent, that dual pivot that they talk about. Sounds very, very interesting and definitely worthy of my interest and our interest. We have to look at this and see if it's more kinematically sound for patients. It's definitely proving to be something my patients seem to be happy with. But when I plan it, I either plan somewhere between the thickness of the implant and cutting to the bottom of that intercondylar notch. But again, in the operating room, if I see that bottom of the intercondylar notch is going to give me too much of an extension gap, then I'll bring it back distal and go more towards the thickness of the implant. Again, it's about trusting the system, ends up being right.
Thank you.
Perfect. So you see we put on implants in this particular system. I like to put on the femur first and then float the tibia. Then I can put the knee through a range of motion and let that tibia find its place. But then you can also see here that on our screen, I don't know if that's showing up, you can assess the gaps. So you can put varus valgus stress on this knee. You can check its balance. You can see how it goes through that range of motion. You can see here all the way from 0 up to, as far as you can bend this knee if you want to, but you can check those gaps and check your balance and see. And you can see here, this one's balancing nicely based on the changes that we made. And then basically once I put it through the range of motion, I know where this tibia will go. You can either pin it here, or you can mark it with a pen and then take off femur and then pin it down. Either.
Great, Dr. Saw. So you're doing trials, and it looks like on the software, it's giving you a full range of motion gap assessment, which looks pretty symmetrical throughout.
Right.
After this point, are you just put the implants in like normal, and how does it kind of go from there?
That's it. Yeah. So once I'm happy with everything, check the gaps, then we're taking off these trackers, and then we're just opening up boxes and cementing. And so for us, we found that this process was time neutral, which is very shocking compared to the other robotic technology we had. Probably in the first handful of cases, honestly, 4 or 5 cases is time neutral. Tomorrow, for example, we're doing 11 joints, and 5 of them are going to be these think cases. So it's not going to slow us down. We can do them anywhere in the day. It can be, first case, middle case, last case. So it's really helpful when you and the staff, most importantly, know you can do a case time neutral, even though it's with robotics.
Great. Well, Dr. Saw, thanks so much for the demonstration. I'm going to continue the conversation with Dr. Kissin and get to some of the audience questions. We'll kind of start the discussion and wait for you back in the studio.
Perfect. I'll see you in a moment.
So, Dr. Kissin, we just saw about a 25-minute knee there. It's quite efficient, I guess. What were your initial perspectives? What stood out to you from that demonstration with this new software?
What stood out was that Alex was moving at about 3 times the pace that he would normally move, three times slower pace, right? You have to understand that for demonstration purposes, I mean, that was really slow motion. That is not how our normal cases go. So without rushing, it was not particularly problematic to get through this case. That's the part that I find the best about this whole system, is how easy it is. I think any surgeon, the other part that to add to the answer to when you said, what do you do at this point, John? We move the robot to the next room is what we do. So let's not forget that part. Some of us run 2 rooms. But to me, any surgeon watching this technique can say, I think I can do this. Ultimately, it's a robotically powered, robotically guided drill that we're all familiar with using drills. And as long as you line it up, as long as you get your registration, your raise, which might be new to some surgeons, it's not that steep a learning curve to do that. Like I said, you be in control of putting in those pins in those bones for the erase, so that you don't get any kind of pin track fractures, God forbid. That should be in your hands. I'm really adamant about that. And once you get through these steps, it's really not such a long trip. And you saw how nobody had to move out of the way. Nobody was in some of the systems. When we're cutting, we have to do a bit of a dance with ourselves. We have to hold a retractor while holding the cutting device, and I want to cut with 2 hands on the cutting tool if I can. It gives me a more solid, more confident cut. So to me, the impressive part is just how easy it actually is.
Great. Dr. Saw, thanks. Welcome back.
Thank you. That was fun.
Great demonstration. Dr. Kissin, Dr. Saw, really wanted to thank you both for us tonight. It was a kind of historical moment for the company, first time doing this live demonstration and utilizing the new software. But thanks so much for the thoughtful discussion. And I also want to thank our viewers for attending this evening. To both Dr. Kissin and Dr. Saw's points, if you want to learn more about the technology, please visit our website, www.thinksurgical.com. If you've been to the website and you want further information or want to take a recommendation to get your hands on the technology, I think that's really a great way to truly understand what this technology does. You can please email marketing@thinksurgical.com. Go ahead and email there. We can funnel that to the right representative and schedule a hands-on demonstration.